Hi guys, this is a review of lecture 69, Physiology. Let's just get to it. We're looking at heart conduction and action potentials. So we have our SA node, and that's going to transmit action potentials to the AV node, and then through, and in between that, through the atrial muscle, and then from the AV node down the bundle of His to the different branches of the bundle, and then into the Purkinje fibers, and then to the ventricular muscle. And so we're having these action potentials passed through the gap junctions in the intercalated discs, and then we're also dealing with different action potentials in the sense that we have our cells that have automaticity are going to have a different action potential curve than our atrial muscle and ventricular muscle, and even our Purkinje fibers, which are going to be kind of a hybrid between the two action potential types we're going to see overall today. All right, but overall for automaticity, our SA nodes located here in the right atrium are going to drive heart beating overall. Why? It has the fastest automaticity, 60 to 100 action potentials per minute. If something happens to it, then it will go to the AV node, which is the second fastest overall. Right, and something would happen to those, right? It would go down the chain. So to learn about action potentials, we need to do a quick review about the cell membrane and the different ion channels because we need to know which ones are involved today. So as a quick review, we have the inside of our cells are more negative than the outside. Generally, when we're at resting potential, it is. Why would that be the case? Well, our insides of the cells have a whole lot of negatively charged proteins, and then our distribution for the relevant ions, which are going to form a concentration gradient, and then also contribute to the different membrane potentials based on their concentrations. Sodium is low on the inside, chlorine is low, potassium is high, calcium is low, and it's the exact opposite on the outside. For our different ways of getting these ions in and out, we have our ion channels, and then we have our pumps. For our ion channels, we have the leak channels, which are ungated, constantly open. We're not going to be concerned with those today, but we are very much concerned with voltage-gated ion channels today. In particular, the question that for our different cell types, the pacemaker cells, and then the ventricular and atrial myocytes, and the Purkinje fibers are what channels are being expressed in the different cell types. And so what do we have overall? We have our fast-gated sodium channel. We have another one, and this is only going to be expressed in ventricular myocytes, atrial myocytes, and Purkinje fibers. We'll go over this more in a second. And then we have, also for sodium, we have the hyperpolarization activated cyclic nucleotide gated HCN channel, which gives rise to the funny current IF, which is sodium movement into cells, and that gives rise to our automaticity overall. For potassium, we have a couple of different ones. We have the transient open channel, which just means that it's not open for very long. Then we have our rectifier fast and slow, and we also have the ultra rapid rectifier. And so these are going to give rise to currents that we label IKR, IKS. Transient open is ITO. And then we have the inward rectifying current, which is IK1, and that's going to be open when you're at resting potentials or near resting potential overall. For calcium, we have the long open channel, which is ICAL for long, and then you have transient open, which is going to be on pacemaker cells, also called the nodal cells. The transient open is ICAT. All right, just a quick reminder about voltage-gated channels, right? They open and close or inactivate at different membrane potentials. The sodium one is a great example. Why? Because as when you're at your resting potential, you're closed, and that means that the activation gate is closed. There's also an inactivation gate, which is open. When you get past your threshold voltage to start depolarizing, the activation gate is going to open. Then when you get to approximately 0 or slightly positive membrane potential, then your inactivation gate is going to close, and your channel is inactivated. And then when you get to when you repolarize the cell, inactivation gate is going to open, and the activation gate is going to close. Right? But this will basically, the different membrane potentials that these stages occur at will help give rise to the shape of our action potentials for different cell types. Then we have our pumps, and these are constantly active, but I just like to mention them because they're going to really come into play during phase 4 for different action potentials, because they are essentially during phase 4 for the most part acting unhindered. Right? They're not fighting against something that's going to be depolarizing the cell for the most part, and they're going to be acting to repolarize the cell in phase 4. All right, so let's just dive into it, starting with our ventricular and atrial myocytes. Our ventricular myocytes in the myocytes in the right and left ventricles are the best place to start. Why? Because the other ones are very similar, but we have, starting with phase 4, where we're at our resting potential. Phase 4, you have, say, the conduction of ions into the cell through a gap junction that's maybe been passed to the cell from another myocyte, or maybe even from a AV or SA node cell. And so that's going to get you past our threshold voltage. And during phase 0, once you get past threshold voltage, our fast sodium channel is going to open. That's going to give us INA, and that's going to allow sodium into the cell. That's going to depolarize the cell. And it's important to know, as you're increasing the voltage, we're going to have our different channels start to open. And so we have the delayed rectifier currents are going to start changing into the open configuration, but they're called delayed because they take a while to do that. And so they're not going to come into play until phase 2 or phase 3. But phase 1, right here, which is our initial repolarization or quick repolarization phase, we have the transient open potassium channel opens, and this is going to allow potassium out of the cell to repolarize, but it's called transient open because it's not open very long. You also have, during this time, the long open calcium channel is going to start to open, which will depolarize the cell, but it's not going to do very much until we get to phase 2. All right, phase 2, the transient open potassium channel is starting to dwindle. It's not open for very long, but you have your delayed rectifier potassium channels have now starting to get into their basically completely open configuration, and so you have a battle of potassium going out, repolarizing the cell, and the long open calcium channel allowing calcium into the cell, depolarizing the cell. So you get this plateau phase overall, and that continues until the long open calcium channel closes. And so at that point, during phase 3, you really just have potassium leaving the cell, as you have the rectifier channels are still open, they're letting potassium out. And as you get closer and closer to the resting potential, you have the inward potassium channel, IK1, opens, and that's active through basically the end of phase 3 and into phase 4 to finish repolarization. All right? And so knowing when these different channels are open is going to allow us to answer different questions, and then it's also a potential target for drugs, right? If we can target these channels that allow different ions in or out, we can change the action potential, which means we can change, right, the rate at which a heart is going to beat overall, right? Because the contraction of the myocytes is going to lead to contraction of the heart. All right, and then during phase 4, we have IK1, inward calcium. It's inward, but it's a misnomer. The calcium, or inward potassium is really leaving the cell, but we have our pumps are working overtime to repolarize. All right. Our atrial myocytes are the same, except they have the transient potassium stays open for longer, and so we can see that as this repolarization phase goes further down towards being more repolarized. And then you also have expression of the ultra-rapid delayed rectifier. And so as a result of these transient open being open for longer, and then the ultra-rapid potassium channel being expressed, you have essentially the overall atrial myocyte is going to go through its action potential faster. It's going to repolarize faster than the ventricular myocyte. All right, so that brings us to regulation. I don't want to spend too much time on this because it's more of a pharmacology thing, but basically, as I said, the channels are a target for drugs. So common ones, we have lidocaine, the sodium channel blocker, and then we have our calcium channel blockers, verapamil, it's one of them. This will be covered more in pharmacology. I'm terrible at pronouncing things. All right, so then our Purkinje fibers, we'll get to in just a second, but we said that they're the hybrid between our non-nodal and nodal cells in terms of expression of channels. All right, so our pacemaker cells, aka our nodal cells, the SA, AV nodes, they are going to be a little bit different because they do not have phase 1 or phase 2. And so that means they have no plateau and they don't have the quick depolarization. All right, and so why is that the case? All right, can't spell. Anyways, why is that the case? Well, they do not express the fast sodium channel. That's the first one. So that's why we don't have phase 1. They also are going to have a couple of new channels. We have HCN, which we mentioned gives rise to the funny current, and this moves sodium into the cell during phase 4. We have a new calcium channel called the transient calcium channel, which is also going to be active during phase 4. And then we have the potassium channel that's activated by acetylcholine, which gives the parasympathetic nervous system a chance to influence contraction of the heart. Okay, and so what's the net effect? Well, we don't have our quick depolarization, so, phase 1 is repolarization, our initial repolarization phase. All right, so for phase 0, we have our long open calcium channel is allowing calcium to the cell, that's depolarizing the cell. Then you have for phase 3, our delayed rectifier potassium channels are now fully open, took them a while, but they're open. They're going to repolarize the cell, especially as our long open calcium is going to close. And so you have our repolarization 3, and then for 4, you have continued repolarization. You have the acetylcholine potassium channel allowing potassium out, but then you also have our funny current from HCN, and then you have the transient calcium channel. They're open, they're going to depolarize and give us our, the two of them together will give us our automaticity. All right, in terms of regulation, you can inhibit HCN with drugs. You can also activate it with neuroepinephrine from our sympathetic nervous system. All right, and of course we know that if you have acetylcholine being able to affect potassium coming into the cell repolarization, basically it would allow us to, since it's acting during phase 4, it would take a longer time. If you are increasing the potassium coming in during phase 4, it would take a longer time to get to threshold, and so that would allow the parasympathetic nervous system to slow down action potentials in SA and AV nodes, which is consistent with what we know about the parasympathetic nervous system. All right, Purkinje fibers, going back to them, they are neuron-like cells. They have all of the ion channels and myocytes and of the pacemaker cells, and so we can see that during phase 4. This looks a little bit more like the pacemaker cells, but they also have the ultra-rapid and the acetylcholine activated, and so we can see a steeper repolarization from this guy, and then, yeah, overall our curve is kind of a fusion of the two cells types. All right, so for our first question from our case-based learning, we had a researcher who's giving different drugs to the cell types to inhibit different channels. And so for question 1, we have inhibit the inward rectifying potassium channel with associated current. We know that IK1 is active during phase 4, and it is going to be a force for repolarizing the cell. And so during phase 4 for the ventricular myocytes, we also have our ATPase, our sodium calcium exchanger working to repolarize the cell. And so really the net result is there's going to be other things repolarizing the cell, but since we have our leak channels depolarizing, constantly active, the net result is our resting potential is just going to be a little bit higher than it was before, right? But otherwise, no changes. For our SA node, we have IK1 is also coming into play during phase 4, and it's combating really the sodium that's coming into the cell to depolarize it. And so if we take away our repolarizing during phase 4, really what that's going to mean is that we're just going to get depolarizing faster, and so we're going to get to our threshold faster, and our overall curve is just going to be shifted, depolarized faster. All right, and so for the next one, what if we inhibit the delayed rectifying potassium channel and its associated current? So basically what this is saying is delayed rectifier comes into play during phase 3 and 4, really during phase 3 and phase 2, and it is going to be a force for repolarizing the cell. Let's potassium out. And so if it's going to be inhibited, well, we know that there's so this is the rapid one that's being inhibited. There's also the slow one. So the slow one is going to repolarize the cell. It's just going to take a longer time. And so what that means is our curve is just going to be a little bit wider, but overall the same. And then the same thing here, curve's going to look the same. It's just going to take a longer time to repolarize. Why? Because we have the slow potassium rectifying channel. It's going to do the job. It's just take a while. It takes a longer time to open than the rapid one. All right, what if we enhance the T-type calcium channel? Well, we know that ventricular myocytes, atrial myocytes don't have the T-type transient calcium channel. They only have the long open type, so it'll make no difference. For the SA nodes, basically this is going to say this is active during phase 4, which we know is this phase right here. So it works to depolarize the cell, and so basically depolarization is going to happen faster, and our curve is going to just be shifted over, but otherwise look the same. All right, take a quick break there. All right, moving on. Our next lecture took a look at EKGs or ECGs. The ECGs are really providing information about change in action potentials, not action potentials directly, but we can get a lot of good information from them. In particular, we're going to be looking at heart rate, calculating that, then rhythm, which we define based on source, and then heart rate, bradycardic, tachycardic, or normal. Tachycardic is fast, of course, greater than 100, bradycardic is less than 60, and normal is between 60 and 100. For our the thing itself, we have really different features that we need to know. So first off, we have the P wave, which is when our SA node is depolarizing, the atrium is depolarizing during this time. Then you have the QRS wave, which is when the ventricle depolarizes. The T wave is when the ventricle repolarizes. And so being able to really look at comparisons between the two, we can shed some light on the ventricles. We'll see in a question in a minute. U wave, generally not seen, could be pathologic, but sometimes it is suggested that it could be Purkinje fiber repolarization, but that's here. It's not normally shown on our ECGs. All right, then we have our RR interval, basically the peaks between our R waves. How do we get our ECGs? It's a great question. We'll go over that in just a minute, but for measuring the heart rate, we'll do an example where you just count the boxes and you do 60 divided by the distance between the two R wave peaks. Our QRS duration, which we can see here, this is the time for the ventricle to depolarize, we kind of already said. The QT interval is depolarization to repolarization, and so this is really the average duration of the action potential for the myocytes. Our PR interval is the time for the electrical signal to go from the SA node to the AV node, and then along the bundles of His to our bundles of His, through the bundle branches, and then getting to our ventricles. All right, so moving on, we have our QT interval, we already said. What if we had a weird-looking ECG? Well, we can have a second R wave, which we call R prime. It's important to know that R wave is always going to be positive. You can have any one of Q, R, or S be missing. So these are a couple of examples. I know when my team was practicing during the practice session, we had an example that was missing the Q wave. And we were like, was that a mistake? No, you can have ECGs without them. And so here's an example of each one of them essentially missing something, with the normal one being right here. What if you have an electrolyte imbalance? Well, if we have additional extracellular potassium, for instance, a lot of potassium in the blood, which we would call hypercalcemia, you're going to have the T wave, which again, T wave is the ventricle repolarizing. The magnitude of the T wave is increased. And then if you have too much calcium extracellularly, so too much calcium in the blood, you're going to have a change in this part right here, which is, as we said, the ST segment. And so I've written QT segment over here, so technically that's true, but the ST segment is shortened in hypercalcemia, and it is elongated in hypocalcemia. All right, so let's take a look at some questions. This is from the practice. We had this ECG is from some patient, and we just want to compare them. So what is the difference between the two ECG traces, and could changes in the conduction of action potential through any chamber or specific cell types create the atypical shape? All right, well, we have P, there's no Q, it's fine. We have R, S is not really very visible, and we have T. So it's our R that appears to be longer, and so we have our wider R wave. We know that QRS wave is when our ventricle depolarizes, and so if that's the case, we know from just the what's going on with the heart, what causes the ventricle to depolarize? Well, we have conduction between the myocytes, right? That's going to allow us to get to our threshold voltage and then allow depolarization. So it's either conduction or depolarization. And so the question is, could changes in the conduction of action potentials through any of the chambers or specific cell types create the atypical shape? Well, so this is where we get to kind of a tricky thing. So we have to take a look at the fact that, so conduction has to do with the intercalated discs between the myocytes. And so QRS, we said, is the ventricular depolarization, but the T is ventricular repolarization. And so we can see that ventricular repolarization stays the same, but this is going to also be dependent on conduction. And so the fact that the ventricular polarization staying the same kind of allows us to rule out conduction as a cause. And so, therefore, depolarization of the myocytes, well, what affects depolarization of myocytes? Individual channels. So question 2b is kind of leading to that. What channels might play a role in action potentials changing the ECG to the atypical presentation? Well, if QRS is ventricular depolarization, it's not conduction at play, then the channels involved in depolarization. So we have two main channels here. We have the long open calcium channels, which we know is really playing more of an effect in phase 2, the plateau phase, than in true depolarization. And so the other channel is the fast calcium channel. Most likely it's going to be this one that's causing the effect in depolarization. So perhaps this is staying open for longer than it normally would. All right, question 2c. Using the typical ECG trace on the top, determine the heart rate and rhythm of the two ECGs. All right, so heart rate, we have two different methods of doing this. We have 60 divided by the resting, or the distance between the R peaks. And so, the way to do that is we just go ahead and we count. Each one of these boxes is 0.2 seconds. So if that's 0.2 seconds, well, we got one big box, we got two, we got three, four, five, and we got half of one approximately. It's a little bit more than half. But we could say, okay, 5.5 big boxes occurred. So 5.5 big boxes, each one of them is 0.2 seconds. So 5.5 times 0.2 divided by 60, and we get 54 beats per minute. All right, this is a shorthand equation given to us. I am not a huge fan because this is in seconds, right? Beats per minute is in minutes. I'd say from a physicist point of view, not cool. Anyways, you never know. Maybe the units of 60 are allowing this to occur. All right, so we have a second method of doing this, which is just to remember, so it's like the quick method, the simple rules. You remember these numbers, 300, 150, 100, 75, 60, 50. And so we counted 5.5 boxes. If it's one box, it's 300 beats per minute. That seems like it's probably like a hummingbird or something that's produced this ECG. Who knows? If it's two boxes between the R's, it's 150 beats. That seems reasonable. 300, 4, 75, 5 is 60, 6 boxes is 50. So we're at 5.5 boxes approximately. So half between 50 and 60 is 55, which is pretty close to our calculation. So that's pretty good. All right, so the next concept was mean electrical axis. So this is really like giving us a little bit of information. There's two things this time. One is mean electrical axis and talking about the different leads is essentially giving us information about how we actually get the ECG, right? The ECG is going to be measuring change in action potentials, and so like what is the pathway that conduction is occurring through the chest. And so we can say that we know in a typical heart, right, our automaticity is going to start. We have our AV or SA node is going to has the fastest automaticity, and so it's going to, through the intercalated discs, it's going to spread its action potential to the atrium, and then into the AV node, to the bundles of His, to the branches of the bundles of His, to the Purkinje fibers, and the Purkinje fibers are getting into the ventricular myocytes. And so we know that the overall mean electrical axis should be approximately from right atrium, which is where the SA node is, down to left ventricle, right, which is right here. So this is the approximate direction of the normal conduction in the heart. And so we can use that to determine if this person has healthy conduction, and their heart is conducting electrical impulses correctly through the mean electrical axis. And so how do we actually go about determining this information? Well, we have a number of different leads that we can set up, and it's important to note that this is measuring the conduction of electrical impulse in the frontal plane, right, also known as the coronal plane. But we're setting up essentially 6 different leads. Lead 1 is from the right arm to the left arm, right? And you can see that from left to right straight line, it's 0 degrees in what we determine the positive direction. That's our first lead. Our second lead is from the right arm down to the left leg, and I would say that's 60 degrees for lead 2. Lead 3 is from the left arm to the left leg, and that's 120 degrees. And then we have our augmented leads, which are not starting at one of these 3 points on this triangle, but starting from the leads themselves. And so you have augmented right, which is going right this direction, negative 150 degrees. You have augmented left, and then you have augmented front, which is 90 degrees down. All right, so basically the idea is that if depolarization is happening along the axis of one of these leads, it's going to create like a positive deflection in the voltmeter that's sensing it, right? The little arrow will tip to the right. And if it's going in the opposite direction of that lead, it will tilt to the negative. The arrow on the voltmeter will tip the other way, assuming this is like an old-fashioned voltmeter. And then if it's at a right angle to the lead, then you shouldn't see anything. All right, so we'll have 2 methods of calculating the mean electrical axis. We have the vector summation method and the quick method, and we'll go over both. All right, so this is our first method. Let's see if I can erase this. All right, cool. All right, so our first method, and I'm going slow on this, but that's okay. We're just going to embrace it. First method to calculate this is to basically choose any of the QRS waves. And theoretically, any should work, but what I read online was choosing 2 with the highest R wave peaks. So that would be 1 and 2. And then you go ahead and basically find the magnitude of this wave. So you subtract the positive part from the negative part, and that will allow you to determine if the net impulse of the electrical conduction was along what we'd consider like the positive direction of that lead, right? So if this is the side's right arm, this is left arm, this is the positive direction, and we'd say this is the negative direction. And so for this is positive, this is negative. We add these 2 up, and we get a magnitude about that big. And so we can go ahead and draw that as a vector, right? So this is along lead 1, and we have a magnitude approximately that big. I'm not being super mathematical about this, but we want to be able to compare it to the magnitude of the second R wave we choose. So this one, all right, you can draw that length. This length right here, this is positive, this is negative. All right, the sum of those 2, this looks like 1 box down, 3 boxes up. So I'd say it's about a little bit more than 2 boxes up in the positive direction, the net is. So this is along the positive direction of lead 2, which is on the screen path right here. And they're both about the same length. All right, so I drew the 2, basically, the fact that we saw an impulse at all meant that there was electricity conducted in the direction of that lead, right? So there must have been electricity conducted in the direction of lead 1, and then there must have been electricity conducted in the direction of lead 2, right? Otherwise, we wouldn't have seen a spike at all. And then we can see that lead 3 doesn't have very much of a magnitude of an R wave, so lead 3, which is this direction, basically we're saying we don't see much electrical conduction in that direction overall. All right, so what's the overall mean electrical axis? Well, it's going to be the vector sum of these 2. And so how do you do vector sums? Well, you do the tail to head addition method. So I'm just going to go ahead and take this second one right here. I'm going to duplicate it. I'm going to just translate it over and put it on the tail of that vector on the head of the second one, or the first one, and then I'm going to draw from the origin point to the head of the second arrow. And so this new arrow that I've just drawn is the mean electrical axis. All right, so that's pointing towards 30 degrees, and it just so happens that the axis is characterized into 4 compartments. This is normal, this is left axis deviation, this is right axis deviation, and then this is extreme axis deviation, right? We should have electrical impulse coming from right atrium to approximately the left ventricle overall, which would be right this quadrant. And so that tells us that overall this guy's normal. Cool. All right, let's do another one. So again, we're just going to do the vector summation. We can choose any two waves, but I'm going to choose the ones with the 2 biggest R spikes because, again, the fact that we see the R wave is indicative that electricity is flowing in the direction of that lead, right? And if we don't see very much, it tells us not very much electricity is flowing in the direction of the lead. It's perpendicular to that lead, in fact, if there's not very much. All right, so I'm going to choose the ones with the 2 biggest R spikes. I see augmented lead left and then lead 1. So looks like we have a big difference this time. So I'm going to start down here. It looks like 1, 2, 3, 3.5. Right, so this is positive, and then they have some negative. All right, so I'm going to add those 2 up. Looks like 1 box overall, so about that long. All right, and then up here, this is positive, this is negative. I subtract the 2, and this is my resultant right here. All right, so we have AVL is overall net positive, and 1 is net negative. So I'm going to draw in the positive direction for that one, and we see that it's longer than the other one, so right, positive. And then in the direction of positive lead, or the positive direction for lead 1, which is along the colored line, and the gray lines represent the negative direction for the leads, slightly shorter, draw right here. All right, and then I'm going to use vector summation, so I'm going to put tail to keep the black one parallel with the black one. Always keep them parallel, and then just add them tail to head. Right? And then draw from the origin. Our resultant vector is right here. And then is this in the normal QR? Is this normal? Well, it's right about there. So we would say this is roughly normal, almost left axis deviation, but roughly normal overall. All right, the quick method. So the quick method is a little bit maybe more straightforward and then definition. Basically, again, it's taking the idea that if we're seeing any sort of mark on this graph, that means that there must have been some electrical conduction in the direction of the lead, right? And so if we see a big spike, that means there's a lot of electrical conduction in the direction of that lead. So basically, the idea is that we're going to choose the lead with the biggest R wave, the most conduction in the direction of that lead, and the mean electrical axis will be approximately parallel to that lead. All right, so that's AVR here, right? It's got the biggest R spike. Then we're going to choose the one with the least R spike, and that's going to be the lead where the mean electrical axis is going to be roughly perpendicular to that lead, right? Not very much electricity is flowing in the direction of that lead. All right, so that happens to be lead 3 here, right? We can see that the R is not very big. All right, so what does that mean for us? We are going to, AVR is going to be the direction that's parallel with it, so looks like it's mostly positive AVR, so it should be this direction, approximately. Our mean electrical axis will be parallel roughly to that direction. And then we have our, actually I think AVL might be a better choice. If we see, this looks a little bit smaller, so we'll choose AVL instead. So AVL is this way, but we want 90 degrees because the mean electrical axis is going to be perpendicular to this, so this is 90 degrees from AVL, so it will be approximately here, and so in between the two of those, our mean electrical axis is going to be about there. All right, and so that would mean that we are in extreme axis deviation, so this is not good. All right, this one, same thing. We choose our biggest spike, which is 3. All right, so in the direction of 3, we should be parallel to that, and then 2 is our smallest spike, and 2 is right here. What's 90 degrees from 2? Well, that would be approximately here, so our overall mean electrical axis should be around here, so this is going to be a right axis deviation. Okay. What about if we are not interested in the frontal plane, the coronal plane? Can we measure electrical impulse conduction in a different plane? The answer is yes. We just have to set up our leads differently. And so our lecture gives us this image, and I found this image to be completely rubbish because it makes absolutely no sense if you have half of the lead marked, but we know that a lead is made up of a wire between 2 points, right? And so if we only have one of the points, this lead tells us nothing. And so what we're missing from this diagram is the second lead, or the other part of the lead, which is going to be on the back. And so if you have conduction along V1, for instance, that's going to be between here, and V2 from the center of the back to the front of the sternum, right? And so basically this will just allow us to figure out if we have conduction in the transverse plane instead of just in the coronal frontal plane. All right, frontal plane is maybe a little bit more useful, but I don't know, maybe there's some reason you would need additional information about the mean electrical axis. All right, question 3, and then we're going to take a break. Instead of asking the assistant to redo the ECG, your attending physician asks you to give them the mean electrical axis and hands you a axial reference system. Determine the mean electrical axis and characterize whether the patient has a normal axis or has a right, left, or extreme axis duration. All right, so again, we can choose any of the leads to determine the mean electrical axis. We had always ended up with a situation where we were using like basically the positive direction of each of the leads. In the cases, we're going to use that here as well. But let's just do the exact same method. So vector summation. So we have lead 2 and we have augmented left lead. And so we have our positive section here. We have a little bit of negative. So negative, positive. Our resultant is going to be about that much in direction of 2. So the positive direction of 2 is right here. All right, and then you can see I've already answered this question. All right. So then we have the augmented left lead. All right, we have our positive section. We have our negative part. Right, this is just saying there's a whole lot of conduction that happened in the positive direction of the lead. Right, so if this is 0 degrees, then you have the positive direction, and then you have the negative direction. So that's 0, the positive, negative. So that means we had more conduction this way than that way. But we did have some on each of these going in the opposite direction. But the net for this one is a little bit less than over here, I think. So in the positive direction along AVL, we have that. Then we're going to use our vector summation. So we keep the arrow parallel, head to tail, and then we draw our resultant. And so our resultant is this way, and we know that normal is anywhere in this region. So this is in fact normal. All right, question 3. Assume, meanwhile, the assistant states, I think the greatest RS amplitude showed up on lead 1, or maybe it was lead V1, and the most isoelectric was lead 3. All right, so we have the V1. Yikes, we have lead 1, and then we have lead 3. All right, so then basically what we're going to do is we're going to use the quick method. If this was the greatest RS amplitude, that would tell us that the MEA is going to be parallel to lead 1, or it's going to be parallel to lead V1. And then the isoelectric one, that just means that it's the one with the least R magnitude. It's conducting the least electricity in the direction of that lead, right? And so lead 3 is going to have the MEA perpendicular to it. So we know lead 3 is approximately this direction, right? So we draw that for lead 1 and lead 3, if that's our combo. Then we draw lead 1, right? Lead 1's this way. So perpendicular to lead 3 would be about here, right? It's not perfect. And then lead 1 positive direction is that way. So in between those two is going to be our mean electrical axis. And so that would be, right, 90 degrees from that is going to be like here-ish. So overall, approximately this, which is consistent with what we saw before. If it was V1 instead, well, V1 is pointing really left to right, from the left to right ventricle transversely. So it's a little unlikely, but let's just take a look. So basically what this is saying is if the greatest magnitude is in the direction of V1, that would mean that's this direction from the left ventricle to, this is the right ventricle, right, transversely. So through the chest versus in the frontal plane. All right, and so this is just not as likely. So we know that, right, the normal heart should be right atrium, where the SA node is, to approximately left ventricle. So that's what this is trying to represent here. And having it come from the chest left ventricle to right ventricle is abnormal, so it's unlikely. So comment on why the assistant is most likely mistaken is because it's unlikely that that would be the direction of the mean electrical axis, and we would need some indication otherwise that something's wrong with this patient. All right, we're gonna take a break there, and then we'll take a look at the next two lectures review. All right, so let's take a quick look at lecture 8 and 9 for review. Starting with excitation, contraction, coupling. We have the steps we're familiar with, but we'll just walk through it, depolarization, and then the power stroke cycle. So starting with our calcium coming into our cell, this is during really phase 2 and phase 3 of the action potential, calcium coming through our L-type channel. That calcium is increasing the calcium cytosol, and in particular, it's going to activate the rhydine 2 receptor channel, Rhy2, which is going to allow additional calcium to come out of the SR. That calcium is then going to bind to the troponin calcium subunit on the thin filament, and so I have that over here. Calcium's binding to the troponin C subunit. We also have troponin I and troponin T. I is inhibitory, C is for calcium binding part of troponin, and then T is for tropomyosin binding part of troponin. So once the calcium has bound to C, it causes the tropomyosin to change configuration, and it will shift, which will then expose our actin to the myosin heads. And so the myosin will then bind to the actin, and after it's bound, it will undergo basically kind of like a sprung spring. It will move. After it is moved, and you have movement, essentially contraction of the sarcomere overall. With the H zone decreasing, you'll have the dissociation of ADP, then you have the association of ATP, and that's going to be converted to ADP, and the process of ATP to ADP is going to basically cock back the head of the myosin, but this myosin ATPase is allowing this to occur. All right, so then this will continue until the tropomyosin is shifted back to its original configuration, which means it will continue this way as long as there's a lot of calcium in the cytoplasm. And so the Circa pump attached to the SR will pump the calcium back into the SR. This is inhibited by phospholambin, abbreviated as PLB, and that inhibits Circa. It itself can be inhibited by protein kinase A, which the sympathetic nervous system can activate. All right, then we have our sympathetic nervous system can also increase the conductance of the L-type calcium channel through neuro or epinephrine binding to beta-1G protein receptor, G-coupled protein receptor on the surface of the cell membrane. All right, so then moving on, we have the concept of cardiac load. And so cardiac load is broken down into preload and afterload. And preload is defined as the wall tension in the left ventricle before systole, which is contraction, or at the end of diastole, which is the same thing. You can approximate it with left ventricular end diastolic pressure, which haven't seen the problem yet, so I don't think we have to worry about that too much. Sarcomere length is another, in the left ventricle, is another way of approximating the preload, also at the end of diastolic phase, and the left ventricular end diastolic volume is as a means of approximating that. But basically, it's the load. Preload is the load prior to contraction, but typically sarcomere length or wall tension is the way that we describe that. All right, overall, it's affected by the total blood volume, the heart rate, rhythm, then ventricular compliance, wall thickness, relaxation properties, which brings us to titin and extracellular collagen. And so titin is this molecule that exists within the sarcomere. It acts basically as a giant spring that's going to resist stretch or compression. And so if you want to change the preload, the length of the sarcomere in the left ventricle at the end of diastole, you could theoretically modify titin as a target. So you can phosphorylate it to make it stiffer, or you can change the isoform, which I don't know if that's possible from a drug point of view. It seems more like different cells would have different isoforms. But anyways, there's the long isoform and the short isoform, and they have different properties. Essentially, the long isoform has more passive tension, depending on for the same sarcomere length than the short isoform. All right, extracellular collagen will also add to preload, again, wall tension in the left ventricle. And so the way to think about this, I think, is we have these myocytes that are surrounded by extracellular collagen, and when our myocytes contract, well, the collagen is going to be essentially compressed, and so it's going to act like a spring as well, and just like titin acts as a spring, it's going to affect indirectly affect the wall tension of the ventricle because it's surrounding all of these myocytes. All right, then we have load or afterload. This is defined as the force opposing ventricular contraction during the systolic phase, and generally undersimplified as ventricular pressure, but it's increased by vascular resistance, outflow tract obstruction, left ventricle chamber size, volume, because there's more to contract, and then a decrease in arterial compliance, aka narrowing of the aorta. Basically, any force that's going to make it harder for the ventricle to contract is going to be considered afterload. All right, so this is just saying that the forces resisting contraction, right, pressure inside of the ventricle is going to make it harder for the myocytes to contract. And then, of course, you have other effects such as intrathoracic pressure in the thoracic cavity, pleural cavity, pushing on the heart is going to make it easier to contract. And so that's why ventricular pressure is an oversimplification, and we loosely define afterload as all of the forces opposing ventricular contraction during systole. All right, then we have the concept of length-based activation. And so the idea here is something that we're probably familiar with, which is, right, sarcomere length is going to have effect on how much force or tension the sarcomere can produce. But we also have this passive tension from the titin and the extracellular collagen, which is going to contribute to it. And then the idea that the amount of calcium that's available to the cell is also going to contribute to the tension that the myocyte can produce. And so starting with overlap, right, we're familiar with this idea that, right, if my sarcomere is, say, at 80% of its overall length, right, it's already kind of contracted, it's not going to be able to give you as much additional tension as, say, a sarcomere that's at, its resting state, or 100% of its length. And then also, if you're, say, past 100% of your length, if you're stretched, then you don't have as much overlap between the myosin, the thick filament, and the thin filament, and so you're going to have less force that you can produce if you're past your maximum length. And so length will, sarcomere length, aka preload values, will affect the amount of tension that can be produced, and then we have these passive tension factors overall that add to it as well, and in addition, the calcium concentrations. All right, so we have a couple questions. Then we'll take a break. We have, you have to present a case to your attending physician regarding patient heart failure. The rejection fraction is low, and other methods, including low inotropy and contractibility. Those are supposed to be interchangeable words. Headstrong pre-med student who's shadowing the attending offers up 3 potential mechanisms to treat the patient. Teach the patient why these mechanisms would or would not work in improving inotropy or contractibility. Focus your answer on the heart. All right, so we haven't gone over rejection fraction yet, but we won't need it. Question 4a says, why don't you inhibit the ranitidine R2 calcium current by using a drug to impair the L-type calcium channel? Well, we have basically the effect of this guy is to release calcium, which encourages contraction, right? Because the calcium binds to the troponin. And so if we inhibit the ranitidine receptor and we keep that current, we decrease that current, we're going to actually decrease contractility. So we don't want to do this. We want to increase contractibility, and inhibiting calcium release would mean less than filament activation and therefore less contraction. So it's not a good plan. All right, and then it says, okay, but I've heard of a new drugs that can increase calcium sensitivity of troponin C. Would that work? That would be good, right? Because if we increase binding of calcium to troponin C, that will shift the tropomyosin and get ready for contraction, allowing the myosin heads to bind with actin. So that would be a good plan. Increasing contractility being our goal. All right, and then 4, what if we were to use a drug that reduces myosin ATPase? All right, so we know that myosin ATPase is directly involved with contraction, as we have, right, it's just involved with getting our ATP to ADP, and the caulking, like the head mechanism is all over myosin ATPase, and so if we were to inhibit myosin ATPase, to directly inhibit contraction, we don't want that. So not a good plan. So one good plan, but 2 not great plans. All right, we'll take a quick pause and we'll look at Wigger's diagram. All right, this is our last part. Let's just get done. So we have Wigger's diagram. This is the cardiac cycle in diagram form. We're familiar with it. We have our blood arriving into our right atrium, then it goes into the right ventricle through the tricuspid valve. From there, the right ventricle goes into the lungs after proceeding through the pulmonary valve, into the pulmonary artery to the lungs, then back to the pulmonary veins to the left atrium, and then into the left ventricle, and from the left ventricle into the aorta to the rest of the body. And so this cardiac cycle is describing all of this in diagram form, particularly looking at pressure, volume, comparing it to our ECG, and then phonocardiogram, which is the lub-dub, when you have, so lub is S1, dub is S2, and then we have S3 and S4, and remember S3 from Kentucky, and the E part of Kentucky is S3, and then S4 is from Tennessee, and S4 occurs right before S1, and S3 and S4 are kind of wishy-washy, blood-filling different chambers. All right, and S1 and S2 are valves closing. So starting with ventricular pressure, this line here, we have ventricular pressure is going to increase as our atrium is closing, right, because it's going to pump blood into the ventricle. All right, so that makes sense. Then we have this point right here, which is when the mitral valve closes, right? So that's this valve right here, at which point the pressure is going to increase in the ventricle as the myocytes are increasing, or are contracting, right? So if you're contracting, the space inside is going to decrease, and we can see that here, right? The ejection of the blood, the ventricle is contracting, and the pressure is increasing as a result. And so the mitral valve is closed, the pressure is increasing, then you have, as the pressure increases, the aortic valve opens to release that pressure, and you can see that the contraction is continuing to occur at peaks as you have, finally the volume of blood is leaving the ventricle. All right, so that's what happens. Then you get down here, and the tricuspid valve opens at that point. That's this valve over here, which allows our blood in from the right atrium into the right ventricle. All right, so not too bad. Over here, the aortic valve closes as we have dumped all of our blood, and then basically the cycle just repeats. We have our aortic pressure is the pressure in our aorta. We can see that it spikes as our aortic valve opens, and it's going to decrease slowly after the aortic valve closes as the blood in the aorta is, moving away. All right, then we have, so that's the top part of the graph. Our blood flow pretty much agrees with that, right? So we have here, our mitral valve closes, we have contraction, our ventricular blood is going to be ejected, so the volume does in fact go down. And then after it's been ejected, then you have the closing of, so the aortic and pulmonary valve close. So that's this guy and this guy have closed, and you're going to have mitral valve open and tricuspid valve open at this point, and the ventricles are going to fill. So you have the ventricles filling, and then you get back to the atrial contraction, pushing further blood into the ventricles, right? And then the cycle repeats. And then if we were to look at the ECG, there's not too much to know here, right? Because we went over the ECG is really about differences in action potential. The SA node is depolarizing during the P wave right here. The atrium depolarizes. The QRS wave is about the ventricle depolarizing, and we can see that that more or less aligns with ventricular contraction, right? Which would make sense. If your ventricle is depolarizing, then the myocytes are just starting to contract. Also at this time, you have the S1 sound, which is our tricuspid and mitral valve closing, so this guy and this guy, right? Why would they need to close at this point? Well, that's so that they can contract and pump blood out the aortic valve or out the pulmonary valve. All right, then S2 is the sound when the pulmonary valve and aortic valve are closing. We have our blood has been pumped from our two ventricles, and so they've gone into these great vessels, and this should close so we don't have any backflow back into our ventricles. All right, and so now that we've contracted, then it's time for more blood to come into our ventricles. All right, so it's really not too bad, as long as you know more or less the flow of the blood through the heart, and then our ventricles are contracting at approximately the same time, right, as our conduction throughout the heart is going from our SA to our AV, down the bundles of His, into our branches, into our Purkinje fibers, into the ventricles. So when our mitral valve is closing, our tricuspid valve is closing, and then when our tricuspid valve opens here, our mitral valve is also opening. All right, so they're following each other, or happening at the same time. All right, so if we were to talk a little bit more about the physics, we had talked about the like preload as the pressure at the end of diastole, and then one of those concepts was, and then we had afterload, which we said was loosely approximated as the pressure inside of the ventricle. But we said it wasn't really the ideal because really it's any force that's making it hard for the ventricle to contract, right? And so we know that the pressure is pushing on the myocyte, the chamber, it is making it hard to contract. But you have so many other things going on that's really not ideal. But Laplace's law gives us a relationship to approximate this pressure of the left ventricle. And so the equation is 2 times the wall stress times the wall thickness divided by the radius of the chamber. Okay, and then that will come into play later as we talk more about the effects of changing afterload and preload. But before we get there, we need a couple other things. All right, so first is a little bit not quite necessary for that particular goal, but good to know. Cardiac output is we have 2 methods for determining cardiac output, right? So blood produced or pumped by the heart. One method is fixed method, which is basically you get the rate of oxygen consumption and divide that by the arterial blood oxygen content minus the venous blood oxygen content. All right, so that's this equation right here: O2 uptake divided by A arterial minus venous oxygen content. And then there's a simple method, which is cardiac output stroke volume times heart rate. But presumably we could be tested on either. Then we have the pressure-volume relationship. And so basically the idea is that we're graphing the cardiac cycle based on the pressure and volumes of the ventricle. And in particular, we use the left ventricle because this is the one that's going to the rest of the body, right? This is the one that is really most important and is going to have higher pressures. So we have this relationship, pressure of the left ventricle volume. And we just trace our different, what's going on here. We have the mitral valve closing, right? Mitral valve closing. Then you have isovolumic contraction. You have contraction of this chamber when the aortic valve is still closed. And so as a result, the pressure is going to spike. Then you get to the aortic valve opening. The blood is going to be ejected from the left ventricle and go into the aorta. So that's what's happening here. We have a decrease in volume overall, and pressure is still increasing overall. Why? Because you still have contraction of your ventricle. And then after that, the aortic valve closes, and you're going to have isovolumic relaxation. Then the mitral valve opens, and you're going to have an increase in volume in the ventricle as the mitral valve opening will allow blood come in from the left atrium. All right, and so again, in particular, this isovolumic contraction, isovolumic relaxation, important to know on the Wigger's diagram. I have it marked here. Isovolumic contraction is occurring right before the aortic valve opens, right? So between here, it's this brief spot, and then isovolumic relaxation. This curve is hand-drawn, so it's not perfect, but really this whole region should be a little bit more vertical. And then isovolumic relaxation, the aortic valve is closed, and then in between that and the mitral valve opening. All right, so moving on, we have a couple of important things to be aware of. The end diastolic volume, EDV, is the volume of blood in the heart when the mitral valve closes, and systolic volume, ESV, is the volume of blood in the heart when the aortic valve closes, and then the stroke volume is EVD minus EVS. Ejection fraction is stroke volume divided by end diastolic volume, so how much it pushed out divided by what it started with right before contraction, just the end diastolic volume times 100, and then we said if it's greater than 50%, that's considered healthy. All right, so we are almost done. What if we were to change preload and afterload for the heart? So this is going to change, can we change stroke volume? So can we use drugs to change things with the myocytes, to change preload, right? Myocyte is wall tension before contraction at the end of diastole. We said that's sarcomere length or wall tension. And so we can definitely change preload. We can also change afterload, which afterload is the forces opposing ventricular contraction. And so you can think of that as vasoconstriction will change afterload. But what is the effect on stroke volume? Are there situations where we might want to have more stroke volume, right? More blood leaving the heart, or we might have less blood leaving the heart? And so let's just take a quick look. So we have changing preload, wall tension before contraction at the end of diastole. This is the diagram that was given to us in lecture, and the lecture notes were not very clear on this, so I struggled, but I'm doing my best. So we have the Frank-Sterling relationship, which is saying if you increase preload, again, sarcomere length, wall tension, then you're going to have a greater stroke volume, stronger contraction, right? So if you have more wall tension before contraction, wall tension it wants to contract, then you're going to have a strong contraction, stronger stroke volume. So hopefully that makes a little bit of sense intuitively. And what's going to happen is that this blue curve here is the highest preload. You're going to have the mitral valve close at a higher pressure and volume, right? So mitral valve up here, right here, if you have more preload, more stress in the wall, then it's going to result in the mitral valve closing at a higher pressure and volume in the left ventricle. And then that's pretty much what happens, but you can see that if the mitral valve closes at a higher pressure and volume, the net result is when you get to the end of the stroke, right, the overall stroke volume is going to be greater at higher preload, right? So another way of thinking about it is if you have more volume in your left ventricle, then wouldn't that indicate there's more wall tension, right? This may be kind of a cyclic argument perhaps, but there's more wall tension, more preload. All right, what if you were to change afterload? So the forces opposing contraction during systole. So we said that this could be the pressure inside of the chamber, but it can also be the any sort of resistance in the vessels outside of the heart. And so if you have more resistance, more afterload, then the idea is that it's going to have the opposite effect of increasing preload, right? So if you have more afterload, it's harder to pump out blood. You're going to have less stroke volume. If you have less afterload, you're going to have a greater stroke volume. And so what you see is that greater afterload, right? There's maybe the easiest way is if you have more resistance in the vessels outside, then the aortic valve is going to open at higher pressures, right? You need to push harder to force the aortic valve open, and so you're also going to have the aortic valve close at higher pressures as well. And so basically the net effect is going to be you're having for higher afterload, you're going to have a smaller stroke volume. All right, and then you can also use changing afterloads to characterize the inotropy, aka the contractibility of myocytes. And this is very poorly explained in our lecture, but basically if you look at the slope by graphing the points, a straight line between the points where the aortic valve closes on the PV curves, and again, it's like you've changed the afterload for a particular individual, you can draw the slope of a line, and basically the steeper the slope, the more contractibility you have, and therefore the greater stroke volume. You compare it to another slope that's not as steep, then you have less contractibility, less inotropy, and therefore less stroke volume. All right, maybe that was as clear as mud. Who knows? Not well explained during lecture, so I apologize. All right, question 5. Patient D enters the cardiology clinic and receives a cardiac ultrasound after having their blood pressure measured. The workup provided the following results. All right, so what's the patient's ejection fraction and is it normal? Well, we just have to know the equation. So stroke volume over end diastolic volume times 100. So how much we outputted over how much was in the ventricle at the end of diastole, aka before systole, aka before contraction. So we started with this, we ended with this. So our stroke volume is those two subtracted from each other, and then our ejection fraction is that stroke volume divided by what we started with times 100. We get 67% overall, which is greater than 50, so it's normal. What's the approximate external work for this patient's heart on each beat? All right, so I find this to be probably not correct in terms of numbers. This is correct according to the answer key, but from a physics point of view, this is bananas. Anyways, so there's two ways of calculating it. One is we do the area under the curve for the PV diagram, and we approximate it as a rectangle, and we do delta P, delta V. Unfortunately, we can't do that. So we have to use the equation that we have, which is stroke volume times, which is delta V, times the change in delta P, which is mean arterial pressure, the pressure in the arteries, the aorta, minus diastolic pressure, and diastolic pressure, and so that's the pressure right before pumping, right? So the pressure in the artery minus the pressure right before pumping. And so we have those two pressures. We also have the stroke volume. So stroke volume times mean arterial pressure times diastolic pressure, and we get 10,000 milligrams of mercury times milliliter, and we also are given 1 joule is 7,500, which tells us that this is like 1.25 joules, right? Okay, and so why is this kind of silly? Well, maybe this is reasonable because your heart beats a lot, and I suspect that's really the answer here. 1 calorie, right, kcal, it's the big calorie you'd see on a package of food. Like a bag of Doritos is 100 kcals, 4,184 joules equal to 1 calorie. So a bag of Doritos is like 100, right, like this many joules of chemical energy, and your heart per pump is that much, many joules, right? It seems like we're off by an order of magnitude, but that's what our answer key gave us from our professor, so I'm sure that there's more going on. Anyways, question 5C, we've increased the patient's preload, but stroke volume didn't change. Is the Frank-Starling mechanism active? All right, so the Frank-Starling mechanism says if preload increases, then stroke volume is going to increase, right? That's saying if wall tension before contraction is higher, right, there's a lot of tension in that wall of the ventricle. It wants to not have the tension, so it wants to squish down, then stroke volume should go up. In this case, stroke volume didn't go up, so we're saying that the Frank-Starling mechanism is in fact not active because stroke volume should have gone up. You hear a third heart sound during auscultation, aka putting your stethoscope on this person. During which phase of the cardiac cycle is the sound generated? All right, this is third heart sound, Kentucky. So it's right after lub-dub. It's right after dub. And so the second sound is the aortic and pulmonary valves closing. And right after that, Kentucky, the third sound is going to be during diastole. So we have systole is contraction of the ventricles. And so at the beginning of that, our mitral and tricuspid valve closed, right? Because the ventricle needs to be sealed such that it can pump out the blood. And so in this case, after the second sound, the aortic and pulmonary valves closing, that says, all right, you've pumped out the blood, now it's in the great vessels. The aorta or the pulmonary artery, we're going to close the aortic valve so it doesn't go back into the ventricle. That's the dub. Right, and so third sound that's shortly after the dub is going to be during diastole because contractions just happened, and so this is ventricular filling. All right, 5E, third sound during Wiggers. Does it overlap with the wave on the ECG? All right, so let's just take a look at Wiggers, and the answer is already going to be ECG. Third sound is going to be here, and we have the T wave, which is ventricular repolarization. So the answer is really going to be no overall. All right, so that's it. That was incredibly long. It took me the entire day to make this review because I was struggling with this concept. So hopefully that's helpful. I'm not perfect on everything, so but step in the right direction hopefully. All right, good job, guys. Bye.